Coming to cardiac MRI, two methods of viability as testing by cardiac MRI. Cardiac MRI can use we can use either for contractile reserve assessment using dobutamine stress MRI, and you can check late gadolinium enhancement imaging using gadolinium based contrast agents, with the latter being the more common and preferred technique. Latter being the more common and preferred technique is used in these cases. So there are two methods of viability testing by cardiac MRI. One is contractile reserve assessment and the late gadolinium enhancement. So gadolinium-based contrast agents are paramagnetic metal compounds that, when administered intravenously, so if you give intravenously, they cannot penetrate the intact myocardium tissue. So this contrast agent of the MRI cannot penetrate the intact myocardial sarcolemma. However, if the tissue is dead or tissue is necrosis or scar, that this can go and deposit it in that part. So GBCs are used to index cell membrane integrity, as living myocardial cells will exclude GBCA when steady state concentrations are reached. In an acute myocardial infarction, GBCA passively diffuses intracellularly. In chronic infarct, GBCA concentrates in collagenous scar that has replaced necrotic tissue. So in infarct tissue and scar tissue, this contrast will be taken, and you can see that late enhancement can be seen. So also evaluation of resting function and wall thickness. Preserved myocardial wall thickness of more than 5.5 mm has a good sensitivity of 95% but low specificity. And another important thing is this end-diastolic wall thickening of thickness of more than 5.5, and with systolic wall thickening. So with systolic, if there is more than 2 mm increase in thickness, that means that it is viable tissue. Late gadolinium enhancement is best observed 10 to 15 minutes after contrast injection, when difference to normal myocardium are maximized. Clinically, gadolinium-based contrast agents are distributed into the extracellular space following an intravenous injection, and you can see the myocardial scar and focal fibrosis can be seen. If the extent of scar is less, as indicated by less than 50% transmural extent of hyperenhancement, indicates viability. If less than 50% of transmural extent, that means that this tissue is viable and you can do some intervention there. If 4 or more dysfunctional segment shows viability, it has a good sensitivity with low specificity. So this is without infarction, 1 to 25%, that is viability is preserved. 26 to 50% viability is preserved, and if it is more than 50% of the transmural tissue is gone, that means it is infarcted, viability is absent, and there is no use of doing reperfusion in this setting. The advantages of cardiac MRI is high quality of images, absence of ionizing radiation, high prognostic value, lower cost relative to nuclear imaging. Disadvantage is that the need for gadolinium-based contrast injection, which although generally safer than iodinated contrast injection, can cause allergic reactions, but can still cause allergic reaction and anaphylaxis. And late gadolinium enhancement shows the expansion of the extracellular matrix. So not only the extracellular, but it can go also bind to the collagen, water, or amyloid. It can go bind into that as well. So it can give rise to a false positive reports. Dobutamine stress CMR is the same as dobutamine stress echo, where you do infusion of low dose dobutamine at 5 to 10 micrograms per kg per minute. Improvement in myocardial thickening of more than 2 mm is considered to be viable. In addition, low-dose dobutamine can accurately predict the development of adverse remodeling following acute MI. With high-dose dobutamine, the presence of indivisible wall motion abnormalities using cine CMR can trigger a biphasic response. The combined use of low gadolinium enhancement and low-dose dobutamine stress CMR has a high specificity and lower sensitivity according to meta-analysis. So advantages of our cardiac MRI is high resolution imaging, high sensitivity and specificity, no radiation exposure, evaluates transmural extent of scar and gold standard, non-contrast viability methods, and simultaneous evaluation for other etiologies of cardiomyopathy. Disadvantage is that it is less availability, higher cost, image quality dependent on ECG getting and breath holding. Contraindicated in claustrophobia, certain metal objects, and advanced renal disease.